Hi everyone. So good evening and hope you have done well in your NEET-PG exams. I heard that the exam paper was moderately tough and there were around 15 questions from radiology and almost all the questions from radiology was from the topics that we were discussing in our routine classes as well as in our VSC session and in our exam recall sessions. So I feel the questions from radiology were a little bit easy only. And today we will be seeing the NEET-PG recall questions and the answers of those questions. So this is one of the favorite questions for examiners in all time to ask the difference between GCT and ABC. So this was a question intended to do the same. So here in this question, they give the clue of a 22-year-old. So the patient was around 22-year-old. That is between so the second decade has been over. So second to third decade. So that is the age of the patient. And here the patient had a history of this pain in his distal wrist. So in the image given, I heard there was a lesion in the distal portion of ulna, and here you can see there is an expansive lytic lesion in the distal third of ulna, and the lesion is extending up to the subarticular surface. So this was a classical case of GCT. So this case can be confusing because of the confusion between GCT and ABC. But in our VSP session, we were discussing that whenever the skeletal maturity comes, then the answer should be GCT because GCT occurs after the skeletal maturity, and there will be expansive lytic lesions involving the bone with soap bubble appearances, and we will be able to see the tuberculations like that. Okay, so how to differentiate between ABC is that in ABC the expansive lytic lesion will be seen, but there will be sparing of the subarticular region. So the subarticular involvement will not be seen in ABC. So this is how you will differentiate between GCT and ABC. And the GCT commonly occurs after skeletal maturity. So this is how you differentiate between GCT and ABC. So in our question, the patient was around 22 years of age and there was subarticular involvement. So if you are seeing the both, then we should give the answer of GCT. So this was a repeat question that we have already discussed in our VSP, that is visual strategical session. Another question, though this was a second question. So this was also a question that we already discussed because this is a case of radiotherapy and outcome of radiation, ionization radiation. So this was a 45-year-old who underwent radiotherapy for carcinoma cervix. So the examiner was asking you to find out the true statement regarding ionization radiation. So ionizing radiation. So the first option was normal cells and cancer cells are equally sensitive. We know rapidly dividing cells are more susceptible for radiation. So cancer cells are always having more susceptibility for radiation than the normal cells. So that option is incorrect. The second option was the effect of radiation is inversely proportional to the square of distance from the source. This is the correct statement because this is what we call as inverse square law. As the distance between the source and the patient increases, the dose of radiation decreases, and that decrease is inversely proportional to the square of the distance. So dose is inversely proportional to the square of distance. So this is the formula. So this is the correct statement. This is known as inverse square law. This is the inverse square law. So this is the correct statement. And we know the gastric in the GI mucosa is very much sensitive because GI mucosa consists of rapidly dividing cells. Since the GI mucosa is made up of rapidly dividing cells, they are very sensitive for radiation, and small blood vessels are also very sensitive. So this is wrong. This is wrong. So the right option was the second, that the option regarding inverse square law. So this is also what we have already discussed in our last year recall session. In the last year recall session, we already discussed that rapidly dividing cells are very much prone for radiation. They are very susceptible for radiation, and they will be easily destroyed by the radiation dose. Whereas neurons, like cells which are very quiescent, that is, which are not at all dividing, are very much resistant for radiotherapy. And also we have to know that as the distance increases, the effectiveness, that the radiation dose will be decreased according to the square of the distance. That is what we call as inverse square law. This is another direct question that they usually ask in this question also. In this condition also, they give the history of sterile pyuria. So this was a young boy with a flank pain, and his urine examination showed sterile pyuria. So this is the catch in this question. And we know when there is sterile pyuria, we have to think in the terms of tuberculosis. So this is a case of Putney kidney. So this is a case of Putney kidney. Here we can see both the cortex and medulla is calcified. The kidney has been shrunken in size. So this is not nephrocalcinosis. This is not calcified psoas abscess. This is a psoas muscle. So this is not calcified psoas abscess, and this is not staghorn calculi. We know where there is calcification involving this pelvic calcium system. That is how staghorn calculus will be seen. This was also discussed in our recall class. Okay, so this was again a repeat question that directly came from our recall class. So those who have seen that classes and those who have attended those sessions, they will be finding it as very easy because all these were repeat questions from the previously asked topics. And here the catch point was sterile pyuria, and the image was very much classical for tuberculosis and Putney kidney. Another, this is also another repeat question. This is also very much favorite topic for examiners because ankylosing spondylitis, because these topics has been repeatedly asked in n number of times in different exams. Okay, here also the patient was around 35-year-old male. This was the fourth question with red eye. Meaning means that there is some sort of uveitis in this patient. The patient had morning stiffness and his chest expansion was reduced. This chest expansion reduction, you may confuse it between tuberculosis, healed tuberculosis, but here it is because of ankylosing spondylitis only. Okay, and the classical image of the SA joint, the chronic sacroiliitis was given. So, and also some people were telling there was dagger sign also seen. So, whenever you are seeing chronic sacroiliitis changes in both SA joints, you should think in terms of ankylosing spondylitis. Also, the history, young male, also there is morning stiffness, red eye, redness of eye, which is meaning about that is giving you a clue about uveitis. When all these factors are there, you should think in terms of ankylosing spondylitis. This was also discussed both in our VSC session as well as in our recall session. In the recall session, when we discussed the same condition with back pain, morning stiffness, and redness of the eye. And this was also so. This was again a repeat question. So the topics, the important topics, are repeating again and again. So whenever you are preparing for next competitive exam, you should be thorough with all these repeatedly asked topics because these repeatedly asked topics are very important for your exams. The topics like ankylosing spondylitis and this tuberculosis, all these are very important. So this is again a very important question. This question was also a repeat question because this question was once asked in NEET-PG 2019, I guess. Again, this was again a repeat topic. Here, this is a 23-year-old female on treatment for infertility. The patient was on treatment for infertility, and we all know whenever in the questions when we came across treatment for infertility, we should think in terms of ovarian hyperstimulation syndrome. So the patient developed sudden onset of abdominal pain, nausea, and vomiting. So the ultrasound given this image is given. So whenever you are seeing a very much enlarged ovary with septations like this, you should think in terms of ovarian hyperstimulation syndrome. For entrance purpose, whenever you are seeing a history of infertility treatment, you should think in terms of ovarian hyperstimulation syndrome because this is very common, and for your exam purpose it is very important. So this was a case of enlarged ovaries giving a cogwheel appearance in ovarian hyperstimulation syndrome. Again, this is a very much repeat question. So the same thing we have discussed in VSV section. So almost everything came from the topics that we have discussed for our visual strategy session as well as your recall sections. So those who prepared very well will find these questions are very easy. So what I am telling you is don't consider radiology as a unimportant topic because almost all the questions in the exam had some clue regarding radiologies. Like some questions had CT showing ground glass opacities, CT showing consolidation like statements. So many clues will be given in terms of radiology. So you should be very thorough while going for exam because each and every question is important. So you should read radiology very well before going to your next exam. So in our session, we discussed how to differentiate between ovarian torsion because ovarian torsion will usually be presenting unilaterally, whereas ovarian hyperstimulation syndrome will be presenting bilaterally because it is a systemic presentation because of hormonal abnormalities. So this was a case of ovarian hyperstimulation syndrome. Again, a straightforward repeat question. So I heard from the students that this was a question with some sort of confusion because this was a 65-year-old male alcoholic patient who came with ataxia disorientation, and patient had a history of trauma 2 weeks back. So he had a history of trauma 2 weeks back. So he was on treatment for alcohol withdrawal and something like that, and his last alcoholic binge was 1 week back. So this was the question, and image like this was given, and some people were telling that this was an image of EDH. Some were telling this was an image of SDH. Anyway, we were how discussed about how EDH looks in CT, how SDH looks in CT. So if the image is given as a biconcave image like this, then it will be EDH, and if that was a concave or convex like this, then it will be an SDH. And one more important thing we have to look is whether the bleed is crossing the suture lines. If the bleed is crossing the suture lines, then it will be SDH. Some people were telling there was in the image it was extending like that and it was crossing some suture lines, and if the bleed is crossing the suture lines, then the answer will be subdural hemorrhage. So that is the take home point, because EDH will not be able to cross the suture lines. Only subdural hemorrhage will be able to cross the suture lines. Again, these things we have already discussed in our previous classes. So that is the concept. If the bleed is crossing the suture lines, then we should think in terms of subdural hemorrhage. That is the catch point here. So this was another straightforward question from our discussion topics, because this was a case of a 35-year-old with a history of fever, cough. His X-ray was given. What was the diagnosis? Here we were able to see some opacities obscuring the right heart border. So we have to apply the Silhouette sign here. We have to apply the Silhouette sign here, because according to Silhouette sign, if the right cardiac border is obscured, then it will be a middle lobe consolidation. So it will be a middle lobe consolidation. So this was again a straightforward question. So these things we were already discussed in our revision topics about the Silhouette sign, and we should remember that if cardiac border is obscured, then that pathology is right middle lobe consolidation. That is what Silhouette sign says. As well as if the diaphragmatic borders are obscured, then it can be either a right lobe consolidation, or if the left diaphragmatic border is obscured, then it can be left lower lobe consolidation. So that is the importance of Silhouette sign. So you should be very thorough, because this is a very useful sign that we apply that in our day-to-day life. That is why examiners are fond of asking things like this from the Silhouette sign again and again, because it is very useful in our day-to-day life, and we will commonly see these cases of right middle lobe consolidation or right lower lobe consolidation like that. That is why they are repeating these questions again and again. I hope that is clear. Another thing that we again discussed is, this is a case of a 30-year-old female who delivered 1 kg baby at 31 weeks of her gestation. On examination, the child had hepatosplenomegaly and CT showed periventricular type of calcification. So here the examiner is giving you another clue. They are telling there is periventricular type of calcification. This is the clue. So there are two types of calcifications. Sometimes the calcification can be seen around the ventricles. That is periventricular calcification like this. Sometimes the calcification can be diffuse. So that is the catch one. If it is diffusely spread out like this, then it will be toxoplasma. And if that is periventricular calcification, then it will be related to cytomegalovirus. So this is a direct straightforward question. These things we have already discussed anyway, because we have discussed that toxoplasma, when it is affecting the newborns, when it is affecting the babies in utero, what will happen is there will be calcifications in the brain, and the calcification will be diffusely distributed in case of toxoplasma. And in CMV, what happens is there will be periventricular type of calcification. So this is the calcification pattern that we get in CMV. So this is again very important topic which has been repeated many number of times. So what this exams taught us, that we have to give importance to the repeatedly asked topics. Always those topics are very important. This is again another repeat question. We know n number of questions has been asked from highlighted cysts. This was again another question with highlighted cysts, because this image is very classical for water lily sign. This is a very classical for water lily. See, you are able to see the redundant membranes of highlighted cysts. So this was a case of a CT image of a 50-year with abdominal pain. They asked you to find out the correct statement. So the statements were also very easy. First statement was the etiology is echinococci. Second option was surgery is mandatory. We know we are not doing surgery for every patient. We will do pair for some of the patients. FNAC is diagnosis. Diagnostic. We won't usually do FNAC for all these patients. Angioembolization is indicated. There is no need for angioembolization in this patient. So the answer for this case is etiology is echinococci. We all know about dog tapeworm, echinococcus and all. So this was again a very simple, straightforward question. So if you know the image, if you know how hydrated cyst looks in CT or ultrasound, then you will be able to solve this question. So that is why I'm telling, even this is a question that we can categorize this question as a surgical question. The clue to the answer is the image. So whenever you are reading surgery or medicine or orthopedics, what you have to do is you have to always see the images. You have to always see the radiological images and learn simultaneously. You should not learn radiology apart, surgery apart. You have to, whenever you are dealing with some condition, whenever there is some characteristic imaging appearance is there for the lesion, you have to see the image. Either you can search Google or any other platforms or Radiopedia or any other platforms. But what you have to make sure is you are seeing the images. You have to see the images and you have to know the classical imaging appearances. So this is again a repeat because we have already discussed all these things in our previous year recall session. How hydrated images, hydrated cysts will be seen in CT and all. In later stages, what happens is it will get calcified. So this was the question that was asked in INI-CET 2022. Again, what happened in NEET 2023? They repeated the same sort of question. So topics which has been asked in one exam are very, very important. So you should be thorough with the topics. That is the key. So this was another straightforward question because here this was a 50-year-old with a history of smoking and the patient had pain in arms and ptosis. So the ptosis, why the examiner has given you the clue of ptosis means they are giving you a clue towards one syndrome, that is Horner syndrome. So the examiner is telling that the patient is having some mass in this region. You are able to see there is some opacity in this region. So there is some opacity in this region causing pain in one arm and ptosis. So they are telling you the patient is having Horner syndrome. So you should be thinking which of these conditions can cause Horner syndrome. You know, upper lobe pneumonia will not cause Horner syndrome. SVC obstruction will not cause Horner syndrome. Lung aspergillosis, we will be seeing some air crescent sign, monad sign like that. There is no monad sign. Only thing we are seeing is some opacity in the region of apex of the lung. So this is a case of Pancoast tumor. So those who have read the theory properly might find this one as easy. Some of you might find this as difficult, but you have to think and correlate between the topics. Then only you will be able to solve these questions. This is some moderate difficulty question. So this answer for this one was Pancoast tumor. This one was another difficult topic because this is not a routinely asked question of axial proptosis. The patient is having some proptosis-like feature. Patient is having right eye pain. She had a history of trauma 10 or 12 years back. That which is significant or not, we don't know. And what they were giving was what they were telling was the CT shows an homogeneous lesion filling the frontal sinus. See, there is an homogeneous lesion filling the frontal sinus. So what is the diagnosis? So you should be understanding that this is not juvenile nasopharyngeal angiofibroma. This is not the imaging appearance of juvenile nasopharyngeal angiofibroma. That will come in the nasopharynx. Okay, that will originate from the pterygopalatine fossa, that region. So here the lesion is completely within the frontal sinus. So this is not JNA. This is not orbital pseudotumor because this is the right orbit, this is the left orbit, this is the orbit, and the lesion is within the frontal sinus. So you can exclude and eliminate and find out. Okay. And this is not frontal meningioma because meningioma occurs from the frontal region of the brain, not from the frontal sinus. Okay. Because for meningioma to develop, we need a dura there. We need a layer of meninges layer. Frontal sinus will not be having any layer of meninges. So that is not frontal meningioma. So the only possible thing is frontal mucocele. So this is a case of frontal mucocele. This frontal mucocele can exert mass effect on the globe. It can cause proptosis, something like that. So this is a frontal mucocele. This is a difficult question, but you can make it correct by excluding. You can tell that meningioma won't be arising from the frontal sinus. You can tell orbital pseudotumors will be seen within the orbit. JNA will come from the nasopharynx. If you rule out each and other options, we will be able to derive an answer. But during that exam anxiety, I don't think that it will be easy for everyone. Okay. So we need some presence of mind for solving these type of questions. And other important thing is we can't learn everything. Okay, some things we have to we have to exclude from these options, and we have to make the answer correct. Another straightforward question was this. They give the classical imaging appearance, this classical ground gas opacities and Shepherd Cook appearance, which is diagnostic for fibrous dysplasia. We know osteochondroma, there will be growth projecting outside like this. Chondroblastoma will be there in the epiphyseal region. Non-ossifying fibroma won't be like this. And this is a classical case of fibrous dysplasia. This was another straightforward question. So this is another question of controversy because this was a case with knee pain for 3 months. Patient didn't have any definitive history of trauma. So they were asking you to find out the correct statement. Some people were telling in the underneath of this image, they were given it as bipartite patella. So there are many controversies going behind this, but you have to understand this is a little bit difficult question. When there is no definitive history of trauma and the piece is, we can see it is well marginated and corticated. So what happens in fracture is the lesion, the fragments will be having some acute margins. They won't be having some well marginated margins like this. They will be having some kind of acute margins. So this is how you will differentiate between bipartite patella and acute traumatic injuries. When there is avulsion fracture of the patella, the fracture margin will not be this much rounded. It will be somewhat acute. It will be somewhat sharp. This won't be this much well corticated. So this is a case of bipartite patella. Whenever you are finding bipartite patella of one knee, the patient can have bipartite patella of other knee. So you have to do screen the opposite knee also. Usually this is managed conservatively. You will just give analgesics, anti-inflammatory, and if the pain continue, if the anterior knee pain persists, then you have to remove the fragment. So that is a treatment. So this is not an avulsion fracture. This is not an upper pole fracture. This was a well corticated bipartite patella. So this is again a difficult question. So you know, always there will be 10 to 15 questions which will be above average level. There will be questions like this. But if you read the question carefully, if you see that there is no definitive history of trauma, and also some of the people, the students were telling in the underneath of this image, they were given it as bipartite patella. If you see the image properly, in radiology, my teachers always used to tell, see all the four corners of the image, you will get a clue. So in this question, the people were telling there was a clue underneath the image itself. So anyway, you just remember that there is a condition known as bipartite patella. This is a accessory fragment which is non-united accessory fragment, which can be seen in very few population. So this is what we call as bipartite patella. Another straightforward repeat question. N number of times this question has been asked. I know every one of you have made this question correct. There is a classical steeple sign. The patient presents with acute onset of fever, stridor, and whenever they are giving an AP view, then you should think in terms of group. And if they are giving you lateral view, you have to think in terms of thumb sign in acute epiglottitis. Oh, so that is another way of answering this question. So this is a classical steeple sign which is seen in case of croup, that is acute laryngotracheobronchitis. So this is another simple straightforward question. 1-month-old child presented with a swelling since birth. Here you are able to see there is a swelling here. So this is a case of cephal hematoma. And we should know the caput succedaneum will be resolving within 1 or 2 days. It won't be persisting just like cephal hematoma. Subgaleal hemorrhage will be also it is difficult to differentiate between cephal hematoma and subgaleal hemorrhage, because the one thing is subgaleal hemorrhage will be, again, it is just like SDH. It will not be limited by sutures. Subgaleal hemorrhage will be, what happens in subgaleal hemorrhage is, since it is above the periosteal layer, what happens is it can cross the sutures, whereas cephal hematoma will not be able to cross the suture lines. So the students were telling it was not crossing the suture lines, it was loculated. If you're seeing a loculated swelling after birth, then it can be cephal hematoma, because it is limited by the periosteal layer. It will not be able to cross the suture lines. So that is the take home point. Okay, so this is a case of cephal hematoma. Another question, I was not sure about the question because the people were telling there was some 30-year-old patient with altered sensorium and on CT showed bitemporal hemorrhage. So whenever the temporal lobes are affected symmetrically or asymmetrically, usually asymmetrical involvement is seen. It is usually HSV infection, that is herpes simplex viral infection. Herpes simplex viral encephalitis will present with hemorrhages in the regions of temporal lobe. So the patient can present with bitemporal hemorrhages. Okay, so that is a classical feature of herpes simplex HSV encephalitis. Okay, herpes simplex virus encephalitis. Uh, I don't know whether the image was given. Some of the people were telling there was no image, only bitemporal hemorrhage in CT. So if you are seeing bitemporal hemorrhage in CT or MRI, always think in terms of herpes simplex virus encephalitis. So I think these are the 16 questions that was directly related to the radiology. But I heard that many of the questions had clues like ground glass opacities in CT or some features in X-ray like that. So radiology is what I have to tell you is what I have to stress up on you is don't don't neglect radiology when you are reading for NEET, okay? Because it is very, very important. 10 to 15 direct questions will come, clubbing with medicine, surgery, orthopedics, or gynecology. Because every modality, every subject requires investigations, and radiology plays a key role in investigating all these conditions. So images will come. So be thorough with the images. Be ready to know all the very much important images which has been asked repeatedly in last few years of examination. This time also around 10 to 12 questions were directly from the previously asked topics. Almost 10 questions were from the topics which has been discussed again and again in VSP sections, exam recall sections, in main topics, etc. So what I have to emphasize is when you are preparing for your next exams, whether it is INI-CET or NEET, always be thorough with all these topics. Okay, that is the true. That is the take-home point. I hope everyone of you have done almost all the questions as correct. I hope we have done our part. So thank you. All the best for your results. Please let us know when you get a good results. Okay, thank you so much.